So, yes,
Thank you so much.
totally driven you all are. Every time to see that people's articles are being discussed and all, and then one fine day to see your own article being discussed, that's such a great thing. I mean, someone acknowledges from your own fraternity, someone acknowledges your efforts. Feels really great.
Thank you
Uh,
so much, ma'am.
Dr.
Thank
Ved
you
is
so
not
much.
here, but I really wish to thank him immensely for considering and making this a point of discussion today.
Thank you, ma'am. Ananta, we can start. We are live now, so you can take over.
Good evening, everyone. We welcome you all to the iHERA's Journal Club. There is a lag, I think. Sorry. So I would like to welcome all of you to the iHERA's Journal Club on this evening. Sorry for the delay due to unavoidable circumstances. We got a little delay by 30 minutes or 40 minutes. So without any further delay, I would like to move on to the Journal Club as such. So today we are going to discuss on a hot topic or the topic of the need, I can say. It is about the journal on DHEA concentrations, stringently regulating the fertilization, embryo development, and IVF outcome. So to move on to the journal club as such, I would like to welcome Charadat Joshi sir to give a welcome note.
Very good evening to all. On behalf of iHERA, I would like to welcome you all for this fantastic journal club again, the next series. And without taking much time, I would just like to say this is an initiative started by iHERA for people like who can have that opportunity to present it, discuss it, and then we can have some conclusion coming out of it. So without taking more time, let's start with this today's most awaited discussion. So you please start, Ananta, take over.
Thank you so much, sir. So to move on to the journal club as such, we have a JC discussion leaders, Dr. Nidhi Singh and Dr. Devan Patel. Sir, we welcome you both. So as a presenter of this journal club, we have Dr. Sneha Tenati with us. Just for a few lines of introduction about her, she is a MBBS graduate and she has also completed her MSc Clinical Embryology from UK. And now currently she is working as a trainee embryologist at Madras Medical Mission, Chennai. Over to you, Sneha.
Ananta, can I just add few words about the journal itself?
Yeah.
Just to start off with a quick note about the journal is that this paper was published in 2021 in the Journal of Assisted Reproduction and Genetics. It's a peer-reviewed journal under the Springer Nature with an impact factor of around 3.5 to 4.0, which is wonderful. And it is quite reputable in the field of reproductive medicine and embryology. And the current paper today, which we have taken up for discussion, is titled DHA Concentrations Stringently Regulate Fertilization, Embryo Development, and IVF Outcomes. Are we looking at the potentially compelling oocyte-related factor in the oocyte activation? So it's a very interesting topic in which we explore the DHAs as a whether they are more important or are they just supplementing right now currently in this current scenario. And it also looks at the possible role in the oocyte activation and embryo quality development as a whole. And I will also request Deven sir if you could speak a few words about the journal before we discuss the journal itself. Deven?
So I think you have already explained in quite detail, but the more interesting thing is normally we do journal club on mostly embryology subject. So this is also embryology, but this time we are having something which is clinical and embryology. So this is really interesting topic. Thank you, Bindu ma'am, also for having this paper with us.
Yes. Sneha, you can share your screen and start, dear.
Sneha, you need to unmute yourself. You are muted.
Sneha, are you there?
Yes, ma'am.
Please unmute yourself. And is your camera on?
Yes, ma'am.
Yeah. You can start here.
Good evening, everyone. I am Dr. Sneha Thanati, and today for the iHERA Journal Club, I am presenting a study by Dr. Bindu M. Chimote and Dr. Anata Chandra M. Chimote titled Dehydroepiandrosterone Sulfate, DHEAS concentrations stringently regulate fertilization, embryo development, and IVF outcomes. Are we looking at potentially compelling oocyte-related factors in oocyte activation? Published in the year 2020 in the journal Assisted Reproduction in Genetics. We all know oocyte activation is fundamental for fertilization and subsequent embryo development. The key trigger here is calcium ion oscillation. Impairment in oocyte activation can lead to total fertilization failure, low fertilization rates, poor embryo development or implantation, and arrest at new metaphase-like stages. Women with advanced age, diminished ovarian reserve, premature ovarian failure, and PCOS are especially at risk. While artificial oocyte activation methods exist, their invasive nature raises concerns about long-term benefits and usability. Following emerging evidence of presence of calcium signatures due to oocyte-related factors, the authors looked into steroid estradiol E2 and DHEAS. Estradiol does affect calcium oscillations, but remains poorly understood. However, DHEAS is the most abundant steroid in the human body. It is produced by theca cells, granulosa cells, and is present in the follicular fluid. They regulate the calcium pumps key for calcium oscillations, and hence abnormal DHEAS levels may be linked with poor IVF outcomes, such as low DHEAS seen in elderly women or women with diminished ovarian reserve lead to inadequate calcium oscillations, or high DHEAS seen in PCOS could lead to abnormal calcium spikes. The objective of the study was to evaluate whether normalizing DHEAS levels could improve embryologic and clinical outcomes, and ultimately proposed DHEAS as an innate, non-invasive, oocyte-related factor influencing activation IVF success. This was a prospective closed cohort study involving 750 women aged 25 to 42 years old and BMI ranging from 18 to 36. The study was conducted from July 2016 to June 2019. The study included women with previous 2 to 3 failed IVF attempts with low or no fertilization, women with 3 to 4 failed IUI cycles with unexplained infertility, fresh IVF cycles for bilateral tubal block or hydrosalpinx. The study excluded donor oocyte cryopreservation or IVM cycles, women with endometriosis, adrenal pathologies, and cancer, couples with smoking, alcohol use, hypertension, and diabetes, male partners with abnormal semen parameters, and also excluded women whose DHEAS levels did not normalize post-treatment. Serum samples were collected on day 2 or 3 of the cycle to measure DHEAS, estradiol, and AMH levels. Follicular fluid DHEAS levels were also measured on oocyte pickup day, and antral follicle count was done via ultrasound. So the participants were divided based on their serum DHEAS level as Group A, which included women with low DHEAS levels of less than 95 microgram per deciliter. This was further divided into two subgroups, A1 and A2. A1 did not get any supplementation, whereas A2 got oral DHEAS supplementation for 3 months. Again, women whose DHEAS normalized post-treatment were only included. The second group, Group B, were women with normal DHEAS ranging from 95 to 270 microgram per deciliter. The third group, the high DHEAS group, Group C, the women had DHEAS level of more than 270 microgram per deciliter, further divided into two subgroups, C1 and C2. C1 received no treatment, whereas C2 received metformin for 3 months. Reason being, metformin significantly lowers DHEAS as well as insulin levels in women. Again, only women whose DHEAS levels normalized post-treatment were included. The follicular fluid DHEAS levels were also classified as low, medium, and high. The study did an intragroup and intergroup comparison of assessment parameters such as fertilization rate, cleavage rate, blastocyst formation rate, clinical pregnancy, live birth rates, and early miscarriage. So, in the results, we see that the intragroup comparison showed the following results. In the low DHEAS group, that is group A, supplementation in subgroup A2 improved embryologic and clinical outcomes. Fertilization rate increased by 43%, whereas live birth rate increased by more than 100%. The study also reported a concomitant rise in follicular fluid estradiol levels post-DHEAS exposure in A2 group as compared to the A1 group. For group C, that is the high DHEAS group, metformin-treated subgroup C2 displayed significantly enhanced embryologic and clinical outcomes in comparison to C1. Fertilization rate increased by 49%, whereas live birth rates increased by more than 100% in the C2 group. For the intergroup comparison showed post-treatment groups, that is A2 and C2 improvement in parameters were comparable with those observed in the normal control group, that is group B. The untreated groups, that is A1 and C1, displayed significantly lower values of assessment parameters compared to the control group, group B. Women whose DHEAS levels didn't become normal post 3 months and were not included in the study, but they showed marginal but statistically non-significant improvement in all outcome parameters, indicating that impetus for oocyte activation is still missing. While the follicular fluid DHEAS subgroup comparison, while comparing the follicular fluid DHEAS subgroups, the best embryologic and clinical outcomes were consistently observed in the medium follicular fluid DHEAS subgroup. Results of the serum DHEAS groups, when compared to those in the follicular fluid DHEAS subgroup, showed that the parameters in the A1 group were similar to the low FF group. The parameters in the C1 group were similar to those in the high FF DHEAS groups, and parameters in A2, C2, and B were similar to the medium FF DHEAS groups. Hence, this study shifts focus from just treating poor responders to a more precise DHEAS level-based approach. The data from this study, as discussed above, strongly suggests DHEAS modulates calcium ion oscillation in oocytes. The limitation of the study was that instead of directly measuring calcium oscillations to evaluate oocyte activation, the study indirectly assessed embryologic and clinical outcome parameters among women with different baseline DHEAS levels. In the future, the study aims to measure calcium ion oscillations directly in donated human oocyte from consenting couples. In conclusion, the study introduces DHEAS as the most potent innate oocyte-related factor that affects embryologic and clinical IVF outcomes, possibly by influencing calcium oscillations in oocyte activation. Thank you.
Thank you, Sneha. And Ananta, can I thank you, Sneha? Can you stop sharing? Nicely presented. Wonderful article and wonderful presentation. So can I have the CV, please, Ananta? Ananta, are you there? Yeah.
Yes, I'm doing.
Yeah.
Is it visible?
Yeah, the color black is, I know, as earlier my seniors were saying, it is giving us mixed feeling today. And having this webinar, we say ki sometimes your mind needs to be distracted. So it's a good distraction when we gain knowledge and we improve in our everyday work in everyday life. Can I have the CV, please, Ananta? The screen is differently sharing. Can you share the CV, open the CV? So coming to our plan of our journal club is basically we have two conveyors here, and it's now I want to introduce two wonderful persons. That is our moderator here, that is Dr. Saroj, and Again, ma'am does not need introduction, I would say.
Is it visible now?
Yeah, it's fairly visible. Thank you.
Yes.
She's the Chief Embryologist and Scientific Director of CARE IVF Kolkata. Ma'am sitting at the border and bringing smile to us today is very great. And our guests today are the author and of the wonderful article. Can I have the CV, please? Dr. Bindu Chamote, ma'am. She's IVF scientific and consultant clinical embryologist. Welcome, ma'am. And she has more than 2 decades of experience in this field. A wonderful person and a wonderful teacher. And our next guest is Dr. Charu. Charu, ma'am. Ma'am is our clinician and expert today, and she has done her MBBS and MD in Diploma in Clinical ART from Amity University. Again, having more than 15 years of experience, and I welcome Dr. Charu. So, I request Saroj ma'am to please take over and continue the discussion
One
on this
second. Yes.
wonderful JC.
Good evening, everyone. 1 second. I think even my. Give me 1 second, please.
Yeah, I would apologize on all of our behalf that there might be some glitches and certain connectivity issues at different. We are joining each other from all the different areas of India together here discussing the general club. So, Saroj ma'am, please, you can start.
Thank you, Nidhi. Thank you, Ved sir. Thank you, Charudat sir, for having us here. And what a wonderful general club we have. I've always been on the other side attending it. And being here as moderating this paper as a clinical embryology paper, it's the honor to do that. And Bindu Chimote ma'am, thank you. Thank you for being here. And it's a great pleasure that we will be discussing your paper here. So now let's come to this thing. Your study provides valuable insights into the role of DHEAs in IVF outcomes. So what motivated you to explore this area of research? Ma'am, are you there? I can't
Yes,
see
I'm
you.
there.
Yes, yeah.
Okay, so see, my PhD I did on follicular fluid biomarkers.
Right.
And I had been doing a lot of biomarkers, right from AMH to GCSF, GMCSF, DHAs, everything I did. And
Okay.
by the time I finished that paper, so we had already published follicular fluid DHAs levels and its correlation with oocyte quality. And then by the time I finished, I can say it's sheer serendipity. That was the time when everyone was talking about artificial oocyte activation. And at
Right.
the same time, there had been a talk about DHEA supplementation to poor responders. So, one fine day, I had to submit a project proposal somewhere, and I said, I'm going to study DHES levels in a set of women. Right?
Okay.
I had not classified them as poor responders or something. So the person at the other end said, okay, you're talking about DHES supplementation to poor responders. I said, no, I'm not talking about poor responders. Now, why I said this is at the same time, there was this other lady who said, why does everyone do so many hormone tests at baseline levels and all that? PCOS है तो DHS तो high, androgens तो high होगा ही ऐसा. And since we had our own hormone lab also, and since I was doing my PhD also, we used to do a lot of reproductive hormones at baseline level, DHEs also being one of them. And I felt, no, हर बार DHEs ज़्यादा होता है PCOS में ऐसा नहीं है. So that way, it all somehow made sense that, calcium oscillation was not in the picture by that time, but DHES in poor responder where it is less, and DHES where it could be more in PCOS women. So that was the thing that gave us the idea that why not evaluate normal women, normal fertile women, poor responders, and hyper responders. So this is the way we got into really estimating DHES levels at baseline. Right.
Okay.
After we found that there was a difference at baseline levels. So it was not that the most important finding that we had from that baseline evaluation was that not all poor responders had low DHES, and not all hyper responders had high DHES levels, or not all PCOS had
Right.
And we found that the PCOS women who had high DHEAS were also the ones who had hyperinsulinemia. So it was one thing leading to another. So it was, to begin with, only DHEAS levels as a follicular fluid biomarker. Then in baseline, and baseline we chose 3 groups, but because people happened to say things at the same time. And by chance we came to know that no, not all poor responders have low, and not all hyper responders have high DHEAS. So now, is there any way where we can bring down DHEAS levels in PCOS women, or is there any way, I mean, where this is the class of women who will need DHEA supplementation? Because if you all remember, there was, I mean, everyone said, ye to sirf ek gimmick hai, DHEA supplementation does not make any effect. So we have to classify the women, which is the class of women who are going to receive treatment. Be it anything, not just for this study. We have to classify our women when we come to any result. We have to do a proper classification, whether it is age-based or whether it is a responder status or anything. So now we therefore boil down to giving DHEA supplementation to poor responders, and now PCOS, whether, I mean, how do we know that what will cause lowering of DHEA levels? And there was metformin, and we did a lot of reading to find out if there was any correlation between this DHEAs and metformin. And there was this one wonderful paper that we found where it was mentioned that DHEAs, I mean metformin treatment lowers DHEAs levels, or hyperandrogenism in women with hyperinsulinemia. So we thought, let's get into this, and that is how our study design came into the picture. I mean, then we got a clear picture. This was, I mean, over a long period of time that we had been carrying out this study since 2000. I mean, my PhD was 2006. So after that, it took a long time for us to come to this particular study.
So, ma'am, like in the low DHEAS patients group, when you were like, was there any adverse effect or the risk of overstimulation of DHEA supplementation, particularly in women whose levels increased to the higher range post treatment? Were there any challenges as such? Because it must have been like, you know, you've given the low DHEA group supplementation. Some of them must have reacted in a different way, not necessarily the way we wanted them to react to.
Okay, so not, I mean, there wasn't any case where the levels went too high. And as it is, DHEAS levels going high will not cause any adverse effect in terms of their own well-being. But then see, we had done, like I said, normal responder women also. So we already knew the threshold, that this is the threshold level of DHEAs that we want within this range. So we had a range not above 275, not below, I don't remember, 95. This
75,
should be the range,
yeah.
right? So if our treatment, how long does it take? So it sometimes 3 months, sometimes 6 months, just as in metformin. Not everyone responds for 2-3 months of treatment. Similarly, this also. But then for our study, we included only those which responded within 3 months of treatment, because that was our project duration we had already given. So so we did not come across any situation where it exceeded that level, because we gave a minimal dose. I mean, just
so what I meant was the androgenic effects could have been there, like, you know, the hair loss and all that. Any effect?
No, so we didn't, because we did not let it go beyond threshold.
Okay. Okay, now, like, based on the findings, do you believe, like, the baseline DHEAS testing should be standardized for IVF patients? Because it's such, if we feel DHEAS has such an important role, and oocyte activation is one of the major things which we see when we are doing an IVF for the formation of good embryos, blastocysts, and everything. So, how do you go about, like, what would you recommend, like an ideal protocol for addressing extremes in DHEAs?
Yes, I would recommend doing, but then it all depends on how feasible economically it is for everyone, because see, people don't even do the necessary progesterone and LH and all. So this is something like an added test that we are asking them to do. So since ours is a research oriented place and we have our own hormone lab, we can afford to do so. It's not a very costly test, but it is an added test. You have to counsel the patient for that additional
But
thing.
for poor variant reserve and DOR, you
Yes,
would recommend to do this test for sure.
definitely.
Dr. Charu, you want to take over or yeah, please.
Just one more thing. Rather than rather than going in empirically for giving DHs to all poor responders, it would make more sense to first test and give to only those who need it.
Yeah, true.
Yeah, thank you, Saroj. Hi, ma'am. And let me first congratulate you and thanks, iHERA, for having me here. Thank you, ma'am. And this was such a comprehensive paper, very well written, and definitely published in a journal with a high impact factor. And I would like to congratulate. It has an element of novelty in it. When I was searching through the literature, very few papers are there with the DHEAS. Normally, there are with DHEA. Plus, those who are comparing with the low DHEAS and trying to normalize this hormone. So, my question is, when you were looking at this, it's been nearly half a decade. So, where do we stand since we are in the era of evidence-based medicine? After so many systematic reviews and meta-analysis have come, where do we stand today?
Okay, so as
How
you
far
said,
have we come?
people talk about DHEA, not DHES. See, essentially it is the same thing because they say DHEA, but then once systemically it becomes DHES. And when we talk of DHEA, it is always DHES. Even the supplements that are provided, because we found out from pharmaceutical companies what exactly is the form, because we couldn't mention anything in a paper like this without being sure of what the chemical form is. So the sulfate group is attached because that gives it more stability. So far as DHEA or DHES is concerned, it may loosely be used. The term may be used as DHEA, but it is DHES. When it goes within the body, it is DHES. Yeah. With respect to how far we are, well, this is a biomolecule that we are talking about. The effect that it is going to have also. So again, it's like every clinic's choice whether they want to do, but then it is worth investing, doing a DHES test, and then defining your strategy for stimulation protocol accordingly. Right, because even after so many years, we are still at a stage where we have every other webinar discussing how to handle what should be the stimulation protocols for POR, what should be for PCOS women, and we still have situations where fertilization rates are low in PCOS women. So why not just one single test? And as it is, metformin treatment is given. To PCOS women. So why not classify? Don't give it to people who don't need it. And similarly for POR, give it to people who only to women who need that treatment. So I would say there isn't a lot of awareness yet. This paper probably we have not publicized it enough, because see, I was in. It's such a vast topic actually that whether to restrict it to just if I talk clinically and if I talk of oocyte activation and calcium generation of calcium waves, I have to justify it, but I couldn't do because we are dealing with human oocytes. We cannot experiment with human oocytes. So we did not measure calcium oscillations. So then it all came down to with respect to embryologic parameters. So like Saroj rightly said in the beginning, that it's a clinical as well as embryologic procedure. So that way, if people look in search for this paper, it is the embryologist more who will come across this paper rather than the clinicians, because the keywords a clinician, even if won't put in calcium oscillation or oocyte activation or this. So therefore it is, if the clinicians understand what is the practical use of this paper, then as embryologists it will benefit all of us also.
Yes.
So
Plus
that we need to understand.
When we go through the Cochrane reviews in 2015 and 2023, I think has come. And when they say there is an increase in the live birth pregnancy of 12 to initially they said 26, then they came down to maybe 20, But for us, increasing the live birth rate from 12% to 20% means a significant thing. For us, 8% increase is definitely something worth going for it.
For us, a percent may matter. For the patient, even that single patient,
one is 100%. Yes,
is 100%. So that is how we look at it when we do anything. Like, for example, people talk for rescue is ICSI. So it's like that. For that patient, even extra 2 eggs, if they have fertilized and if they have given an embryo, they are worth it.
Very true. Very true. Plus, ma'am, there was when you gave the metformin, one thing that struck me when we give metformin in PCOS patients. Obviously, we have not seen much of the DHES levels in the patients. We go for testing of DHES, but in a subset of patients, not in all patients. But when we give metformin to PCOS patients, to hyperandrogenic patients, the clinical hyperandrogenic patients, it has been seen that AMH levels come down. In your paper, it shows that AMH levels have not come drastically down. Was there some any specific reason for that?
AMH levels come, no.
I mean, yeah, when DHES is coming down, the insulin, it improves the insulin sensitivity.
Yes, yes.
So androgenicity is going to fall. Similarly, the AMH is going to fall.
Okay, so see this paper again, if you see, it is just 75. We are giving a minimal dose and just 3 months treatment.
Yeah.
Right?
So you've given 500 milligrams of
wait, I'm confusing between the dose of DHE and metformin.
DHE is 75, but this is 500.
500. So that is a standard dose given, and no, we did not see. And see, in case of PCOS women, such women as it is have abnormally high. I mean, we see 11 AMH and 15 AMH also, or anything more than, I mean, 4 and 5 AMH. So no, we did not see any drastic reduction in AMH levels in PCOS women.
Okay.
Ma'am, I think the question here, what Dr. Charu was trying to ask is that metformin is used to lower the DHEAs in PCOS patient, but metformin has its different pleiotropic effects, right?
Yes.
So how do you isolate the effect of DHEAs correction from improved insulin sensitivity or other metabolic parameters? Like, how do we understand that this was due to metformin only and not an effect of both metformin and DHEAs kind of?
No, metformin was used to
because
bring down
metformin, ma'am,
DHEAs levels.
metformin was 1500 mg per day. That was a TDS, 500 mg TDS. That's it's a high kind of.
It's on a higher side, yeah.
15, yeah, it's on a higher side. So is there what I was trying to understand was we are here saying that the DHEA supplementation and everything did improve this thing. But when you are giving that kind of metformin, right, we are trying to lower the DHEA by giving the metformin. Am I right?
Yeah.
Yes. So how do you isolate? Like, how do we come to understand that for in these patients, since the insulin levels improved, the DHEA is improved kind of. So is there any parameter which you were taking into consideration?
No, baseline DHEAs levels. So we did insulin, we do baseline insulin, DHEAs, AMH. I mean, 10 different things we do in the baseline, right? So women who had high DHEAs, high insulin, and what? I mean, and then accordingly, we decided whether to give them metformin or not, depending upon the baseline DHEAs levels.
Okay.
So the point is not that, I mean, metformin to lower DHEAs when DHEAs was too high. More than 300 or so. Yeah.
Yes. I think I'm also this thing.
Maybe if you permit me, since no one else is sharing the screen, I want to show a figure, I mean, with the help of figure, how we correlated that with oocyte activation.
Right.
So I'll just quickly, if you permit me, Nidhi.
Yes, ma'am. We'd love to that.
And one more question, ma'am. Sorry.
Yeah.
That's just out of curiosity, since I am not in this. how do you actually measure the calcium oscillations? You said
No,
nothing.
no, we did not measure.
They
See,
didn't
I know
measure,
you
no?
did not measure. That would be the future aim. It's
Yes,
just
yes.
for the theoretical knowledge.
Yes,
That how
yes.
is it measured?
Just a moment.
I was actually wondering, ma'am, the design, the whole paper and the whole this thing was so detailed and so well controlled. And like, did you face any practical challenges keeping up the stimulation protocols for so many patients and, uniformly across so many patients? There must have been a lot of challenges also.
Yes, yes, definitely. Just a moment. Why is it not
Definitely, it's an
showing me?
extensive paper. Extensive paper.
It was really an extensive paper.
Somehow I'm not being able to share.
I
Okay.
think they should
Yeah,
allow.
yeah, yeah. Now I can. I hope.
Ma'am, half of your screen is visible.
Yeah, I'll show.
Yeah. Yes, ma'am.
Okay. So, how, because that part we have not yet discussed about
The
oocyte
calcium
activation,
oscillation. Yeah.
calcium oscillation. So quickly, this is one figure which I think by now everyone knows how we have, we generally talk about how PLC zeta causes oocyte activation by triggering the generation of the calcium waves. Now, again, while reading, I came across that there are several sperm factors. It is not just PLC zeta. PLC zeta is just one of them, which is more studied. But then there are several others. And again, at the same time, there was one paper which discussed that some molecules within the oocyte. So there is one very interesting paper about oocyte factors in oocyte activation. If you have noticed here, I have not mentioned oocyte factor in oocyte activation. I have said oocyte related because
Yes.
this is DHEase is not present within the oocyte. It is present in the theca and cumulus granulosa cells, the COC complex in theca. And externally, it acts through its receptors, just like PLC zeta does. But then sperm factor, you can say. Oocyte factor, I wanted to be very, because I wanted to get it published in a good journal. I was very careful not to mention any terms which they might just reject that, no, this is not an oocyte factor. So this one we know. And then we also know that there is a lag in cytoplasmic and nuclear maturation, and how, I mean, this again, so again, lot of studies on artificial oocyte activation and how the various chemicals and all, we are not sure how it works. Even after so many years, not everyone uses these methods despite getting low fertilization rates as well. So,
yeah, sorry to interrupt, ma'am. Have you ever encountered these side effects because of the or deleterious effect on the embryos or the oocytes because of artificial this thing oocyte activation? Has there been any clinical or this thing?
I haven't done many. I did a few cases because I wanted to do this study. So I couldn't go ahead without actually myself doing artificial oocyte activation. Although I did not believe in it, but still I did. But no deleterious effect on the oocytes as such. But then I cannot say that there was a huge difference by doing this, by following these techniques. So that. And so why did I use DHES? So these figures might help you. See how DHES, like Sneha already mentioned, that these calcium pumps which are required to pump in and cause, I mean, excite the cells to produce more calcium. So DHES plays a role. Here you can see in the figure how DHEA or DHES works through these pumps. So this plasma membrane calcium pump as well as the sarcoendoplasmic reticulum. Now we have to also understand that mitochondria and the smooth endoplasmic reticulum, these are the two main parts which the organelles which play an important role in the calcium activation process, because it is from there that the calcium waves are generated, the stored calcium is released, so to speak. So, and then DHES regulates these pumps, that is PMCA and SERCA. And in mouse oocytes, it was found that these are the very pumps which play an important role in generating calcium waves in oocytes. So in mouse oocytes, these are the pumps which play an important role, right? And also, so up till now, when you talk of the complete pathways, when we talk from cholesterol and all, how steroids and everything are produced, so we found that DHEA, it was earlier considered to be the inactive form and not a part of the entire cycle. But then we found that DHEAs itself, so if you can see here on the screen, the DHEA sulfate, can you see my marker there?
Yes,
The
yes,
pointer?
yes.
Yeah, so how it also is an active part of this pathway that leads to the generation of the estradiol. The estriol basically. So DHEA sulfate basically in estriol, and also through so it keeps on converting between DHEA and DHEAs, and how it helps in the formation of the estradiols, right? So this is also an important finding that we came across. So the calcium pumps are regulated by DHEAs. DHEAs also is an important part in formation of estradiol. Then how it is present in granulosa, theca cells, and it enters the oocyte via anion exchanges. So it not just the pumps, but then there are anion exchanges also that can help the DHAs to enter the oocyte. So see, even if indirectly, I have to justify how these can actually work and bring about a calcium generation of calcium waves, and therefore oocyte activation, and therefore better quality of fertilization and embryo development, right? So this is how. And then see this also, how DHEA helps in increasing the number of oocytes as well. If I'm sure you all have seen this earlier, how inhibin B, right, from the, I mean, adrenal cortex, adrenal gland, then from here the inhibin B acts on the ovarian theca cells. This in turn produces DHEA, and how they cause in, I mean, I cannot explain everything now, there's a lot to be discussed, but how the follicle number and quality can increase. So this study was done in a different context earlier. So how the various cytoplasmic organelles, how the theca cells, granulosa cells, everything, everywhere you see some of the other role of DHEA being, I mean, playing an important role. And like I said, in PCOS, how we found that if DHEA is supplemented to give polycystic. So if you give DHEAs to women, I mean, mouse models, it can produce a polycystic ovary kind of a picture. So DHEA supplementation, that is high DHEA state, was created because we don't know whether they have PCOS or not, right? So there was this particular study where rodents, when supplemented with DHEAs, generated polycystic ovaries, and therefore now they wanted to study and mimic the exaggerated. When PCOS was being studied in mouse models, they had to create this mimic the PCOS kind of a status in humans by supplementing DHEAs. So, and also in cumulus cells, DHEAs caused abnormal metabolism of glucose and lipids. So this is physiologically, this is what happens. I'll just increase the
That
size.
suggests that we need to be more careful while prescribing DHEAs right and left.
Correct.
Like in
Yes.
rodent
That is what,
models.
when people said that DHEAs does not work. Why does it not work? Because we cannot empirically, just as metformin we cannot give to all PCOS, DHEAs we cannot give to all poor responders. Now, how DHEAs works in PCOS women, see how it blocks the pentose phosphate pathway, and thus it affects the entire metabolism. See, DHEA inhibits the glucose 6-phosphate dehydrogenase and of the pentose phosphate pathway, and it affects the glucose and lipid metabolism. So we are talking about metformin treatment to not just people who, women who have high DHEAs, but PCOS with hyperinsulinemia. That is the line. Only then will DHEAs act. Metformin will act, right? So we are talking about hyperinsulinemia, and high DHEAs, and then metformin treatment. Not any one of these kind of things, right? I hope I'm.
Ma'am, so basically the impact of DHEAs on oocyte activation we haven't been able to directly kind of calculate the calcium oscillations. But you have done it by looking at the
Yes.
formation, the cleavage, I mean the embryo quality one, and second by the level of follicular DHEA and follicular fluid.
Correct.
Right?
Correct.
Is there anything else we are missing here? Like,
No.
is there anything else which kind of let you know like it impacted directly or something of that kind?
No. So we need to see whether really the calcium ion, I mean, the generation of calcium waves. There are studies, somehow I don't think I have it here.
Ma'am, can
actually,
we
we
ask
were
a
more
question?
interested
Devin
in that
sir,
only. Yeah.
Ma'am, can Devin sir and I ask a question to you?
Yes,
Devin
yes,
sir,
please.
Devin sir, please.
Yeah, so ma'am, I'm having one question.
Yes.
Like there is low sub control group, correct? And one other same subgroup which is having low DHES, you have given oral implementation.
There is a control group.
Correct. Yeah. So out of this both group, was there any patient which was done OM pickup earlier, and then second time you have given DHES, and then you have checked if there is an improvement or not?
Yes.
The same patient.
So yes, there are previous. That's what. See, what is our inclusion criteria? Yeah, the inclusion criteria are the patients which had previous either no fertilization or low fertilization rates. So that was our inclusion criteria. I think Sneha has already mentioned. It's not here in my slides
Sneha,
at the
can you
moment.
show the inclusion and exclusion criteria?
Wait, let me see. Sneha, please, can you share? I'll stop sharing.
So my question is like exact 1:1. Like if you take particular like 5 patients, and previously they were like poor fertilization and all that. Because see, I want to ask regarding embryology perspective, the fertilization rate previously was 55 with lower control group, and it has improved to 79% fertilization rate. So basically, it is really showing there is an improvement.
Yes.
So as an embryologist, yes, I am really impressed that yes, there is something positive going on. But was the same group, like at least there were patients who were having in both the groups?
I didn't get this. In both the groups in the sense?
Same patient was there in both the groups, first time and
both
second
the groups
time.
In the sense?
So just for example, there is a patient number A in
okay, you mean
1.
To say that one who had undergone treatment had normal DHEAs and then was considered as a normal subgroup. That is what you mean to say?
Yes. So then you have given DHEA
no, but
supplementation.
Then we are not going to do a cycle again for that patient, isn't it? I mean, that what I understand from your question is that there was this patient who had, suppose, low DHEAs. We supplemented DHEAs, right?
No, first time pickup was done when there was a low DHES, correct? And then same patient was given DHES, and then you have checked. So then will be proper comparison.
That is only there in the study, sir?
Yeah, that is only there. That's the thing.
That was those patients.
That is how you say that improvement in fertilization rates from 55 to 79 is that.
Yeah, and I think, ma'am, those patients have been excluded from your study who have not shown a rise after the DHES supplementation. Or who have not shown a fall in the DHES level after the metformin.
Yes. Yeah. So what you see, like there was equal, since it was a prospective study, we wanted a good part to the study. So 150 patients in each of the groups. But then when you compare, Sneha, you haven't taken the results, I guess. So if you have the result tables anywhere, maybe I can.
So the tables, Sneha.
Yes, ma'am. I do not have the table, but I do have the.
Okay, so the number is obviously did not remain 150. The distribution was 150 in each group. Here, this is the study. This was the design. So here it was equal distribution. We wanted 150. But then finally at the end, it was not 150 when we saw the results. Because the patients who did not show any demonstrable change in or the desired change in the DHES levels, we did not include them in the results, final results. Do you have any other table, result tables, Sneha? Somehow it did not strike
Just
me that I
share the
should.
article itself and just
You can share the article if
increase
you
the
have.
size, screen
Yes,
size.
ma'am, I can share the article.
Directly share the
Yes,
PDF.
you have
That will be
excluded one patient from the A2 group and one patient from the C2 group.
Yeah.
Those patients
Ma'am,
have been excluded for the result.
Ma'am, my question to you is, did you go in depth to the oocyte or embryo changes? Did you see anything drastically increasing or improving, except the outcomes definitely we're seeing, but you can see the quality was improved or the
It is
oocyte.
about the cytoplasmic maturation.
Yes,
So,
ma'am. Yes,
as
ma'am.
it is even irrespective of any study, what we see, or I have this habit of seeing, is that every oocyte, when we do ICSI, of course, the COC complex only when we do conventional insemination, but when we do ICSI, we see we can see the oocyte. So, proper documentation of how the oocyte looks like during ICSI, and next day fertilization also. So it is not just the presence of one polar body that we mentioned. We see the granularity, the central granulation, then whether it is a uniform distribution, how does the cytoplasm look. So it is more about the cytoplasm, although there are studies which also say that DHEAs can have genetic effects as well, but then we saw with respect to the cytoplasmic maturity, and definitely the kind of cytoplasm that we saw was, so see, 137, not 11 only. So we had 137, 128, metformin 137, 134. So out of 150, so many patients less which did not respond to the treatment properly. So finally, oral DHA supplementation were only 137, no DHA supplementation 128, and so on. So this is how we went about it.
Ma'am,
And
I
ma'am,
have one question. Sorry, who?
Yeah,
yeah,
yeah.
Can
please
I
go ahead.
go ahead? Yeah, but like you have taken age group between 25 to 42, right? Let's say the advanced maternal age 35 and above. Did you see like was the result, I mean the supplementation, the influence of DHAs on oocyte activation, did it affect, like how was it in the maternal age
Age
group?
group.
And also, like, did you see the oocyte quality? Because generally the oocyte quality is comparatively bad when you see
Yeah.
maternal age group. Like, did you
Can you
see any
please show
changes there?
table 1, please? Okay, so now see, again, this forms another arm of the study actually. If
Right.
we try to, because now if I try to, sorry, no, it's not here. I might have written in the results. So see, too many parameters. If I try now, why did I take such a huge age span? Is because we have taken poor ovarian reserve or poor responders as well as PCOS. So not this one. I think it's not there. In the next table, does it give the demographics?
Go down, Sneha.
Yeah. Is there another table? I don't remember also now. No. It is probably mentioned in patient age. See, 36, 37, 35, 37. So these are the mean ages. Yes, with respect to now, if I try to bifurcate this still further with respect to age, everything changes then. So
No,
this
ma'am, I'm not for the study itself,
Ah.
but in general, when you were going through this, did you see, I mean, was the effect exactly what you were looking for in the maternal age group, or you felt they disappointed you? What I
No, there
wanted to
are
ask.
times when not, it's not perfect, not always. See, these are all mean or averages we talk about. So there are instances where despite, I can say that I saw good oocyte quality, but then not necessarily a good fertilization or embryo development and all. And we cannot take singly, it's in entirety when we give the results. But no, it is not necessary that all the time we got extremely satisfactory results. And not that we are looking for it also, that way. We cannot expect 100% improvement.
No, what I mean is, was there any surprise? Sometimes it happens. You feel this group might not actually do good, but then, uh, contrary, maybe that group did well or something of that kind.
No, as per the groups that we had divided, yes. Now within that, again, I mean, I have not really looked into bifurcating them into the various ages. So,
Okay.
or maybe I have mentioned it also. I don't remember.
And I'm now, as an embryologist, if I ask one question, let's say we have treated this patient with DHA supplementation and everything, though we know the DHA levels were low, and they are cases which might result into low fertilization or total
Yes.
fertilization failure going forward. Now, when
Yes.
you're doing a pickup, do you completely rely, okay, I have given the DHA supplementation, I don't need to do artificial oocyte activation? Let's say if I don't do and the results are not good. So would you feel that maybe you could have done an artificial oocyte activation on that for better result?
No, see,
Would
now
you go ahead?
that is,
Yeah. I'm just asking, like, let's say this is a study you did, but obviously the patient is not going to come to you again and again for an IVF, right? But if you feel they are falling into the criteria of using an artificial oocyte activation, this thing, we have tried DHA supplementation, but then this is so unsure whether that is really going to give that response in this patient. Understood what I'm trying to say?
yeah, I got it.
Yeah.
So the thing is, see, it all depends upon your conviction whether artificial oocyte activation is going to work or not. There are several who do artificial oocyte activation and they are happy with the results. I never believed in that, and somehow the results were not too great as well. That, I mean, I should continue doing that. Right. So, see, and we cannot put two confounding factors there. I mean, do
Right.
DHEAs also and do oocyte activation also.
No,
For
but I'm saying you wouldn't do an artificial oocyte activation because you don't believe in it, right?
yeah.
But let's say if that
Okay, you
same
mean to
patient,
say that, okay, so you have given DHE supplementation and yet you also do a artificial oocyte activation.
yes, because
Well,
you're not sure whether that patient has responded according to our likeness with the DHA supplementation. It might
yeah,
so happen that the patient hasn't responded also. So do
yes.
you let that cycle only go that way, or would you, I don't know, whether half,
No,
like
I
we do
haven't
a
done it.
half
I
sibling or
haven't done it.
something?
No, I haven't done it. I mean, I
Okay.
did not even think about it that, okay, if she has not responded, let me do oocyte activation. No, I haven't done it. So, I mean, I cannot comment. And
Okay. Okay.
yeah, but then see, we keep trying things in the laboratory as long as it is feasible and it does not
Yes.
harm the oocyte or embryo or the patient results eventually, it is all right. See, sabhi to haath pair hi marte hain na, to try
Yes,
the
ma'am.
best possible for the patient. है ना? So if you think that, okay, I have done this DHE supplementation, but it might not be sufficient, let me also do artificial oocyte activation. You can do probably.
Ma'am, there's a question in the chat that DHA
Yeah.
is a substrate which is converted to estradiol. Is there any other
Yes.
direct action of DHA apart from this effect discussed with all
See, there
right
are
now?
many things.
This is
Many
on all
things.
three of you, for all three of you.
No, for this particular study, it is, see, therefore, that means what? It acts some way on insulin, right? We are talking of DHEAs in calcium, generation of calcium waves. We are talking of DHEAs as metabolite or a molecule which helps in the formation of estriol. Then we also talking about the calcium pumps, right? So and insulin sensitivity, right? So these are the roles that we have discussed. Apart from that, as far as oocyte is concerned, I also showed one slide where right at the time of recruitment of follicles, right? So where, just as we talk about in the previous cycle, it is through inhibin B, inhibin A and inhibin B, recruitment of follicles in the previous cycle. It starts in the previous cycle, right? So for that also somewhere DHA, I have not gone into the detail of that, but there is this pathway which I just showed in the slides that I shared, that DHAs also has a role somewhere in the recruitment of follicles.
Yeah,
And
can
it
I
makes
chime in?
sense also. It makes sense also, because if DHA supplementation is going to give me a better quality out of the oocytes that I have, that I'm going to get, it might as well increase the number, which I cannot vouch for, but logically, yes. Could be.
Can I put my view? It's just Nidhi, it's just because DHEA is a part, it is an androgen which is normally secreted in the body. So it is a pathway from DHEA. Normally, it is produced in the ovaries. A part of it is produced in the ovary. DHES majorly is produced in the adrenals, and partly it is formed from the ovaries and partially gets converted into the periphery into DHES. There is a combination of this thing, interconverting hormones. So there is a pathway which converts androgens into estrogens. So once DHEA is not there, follicles will not form. That means if androgen is not there, the androgen is present in the theca cells. From
Correct.
theca cells, they go to internal cells, granulosa cells, where it is converted to estrogen. When there is no conversion of androgen to estrogen, follicles will not grow. That is the state of hyperandrogenicity, which we produce by giving the ovulation induction drugs like letrozole or clomiphene. We are producing a state of letrozole. Maybe we are producing a hyperandrogenism. Hyperni, in the milieu, we are producing a hyperandrogenic state with an idea that once the androgens are more, androgens means the substrate for estrogen is more. Once the substrate is more of the follicle and good quality oocyte will form. That is the logic behind. And normally DHEA is present in the body and it is required in the body for the normal growth of follicles.
Fantastic. I couldn't have put
Yeah.
it better than you. No,
My
so that
view,
brings me to another important point, Nidhi. See, DHEAs, we have another paper later for implantation. See, we need androgens as well as estrogens, a good balance of androgens and estrogens. And it is said that DHEAs is an estroandrogen. Right. So it is very convenient. So somehow it works as a switch to maintain the balance between the androgens and estrogens. If that balance is disturbed, that is where things go wrong. And see, when I say that, this is not just one thing. There are too many other molecules which are playing a role in doing all this. But then DHEAs is an estroandrogen, and it works through estrogen receptors also.
Yes.
So the receptors are of the same kind. So that is how very conveniently, when needed, it will convert to androgen, or it can convert to the, help in the formation of estriol also. So
Yes, to
maintaining
maintain
the
a
balance
homeostasis.
between androgens and estrogens also is one of the properties of this molecule, DHEA. It's a very interesting molecule. Very interesting
Yes,
molecule.
that is why when DHEAS is high in the PCOS, this leads to follicular atresia. So the
Correct.
follicles are stunted at the 10 or 11 mm stage only. They do not
Yeah.
grow.
my favorite question to my author, I would say, is always ki you have written an article, ma'am, from the side of the kids. I would say, ki what was the statistical part which you did, how you decided. I've always asked this question to all the authors in the JC. So what was your you can say the path of you made the groups, how did you select them, and how did you came to an outcome ki I will do these tests? What was your, just if you could give us few ideas how to go about in the statistical part, ma'am.
Yeah, so basically, first and foremost is to select your study, select your subjects that you would be including in the study, then the inclusion criteria. This I'm saying in general for any
Yes,
research.
ma'am, definitely.
Inclusion criteria, exclusion criteria. Try not to break up a lot. Stay focused, because there are n number of papers discussing on the same topic as well. But then how different are you from the others? So the first and foremost is to go ahead and try to, either you will prove any hypothesis or you will not be able to prove the hypothesis. But then even if you cannot, if I had started with this saying that DHEA has its effect, if it did not, I could still publish a paper saying that DHEA does not have any effects on poor responders. So there is no use supplementing, or for PCS also. So any study can be useful. It is not necessary that you get a expected result all the time, and therefore you need not get disappointed. So go with the conviction of doing a study, select your subjects, classify them properly. Very simple things, comparisons also you can do. Now selecting not just the statistical analysis, before that, how many patients you are going to include in the group. See, there are various categories of studies. It could be a simple comparative study. You can say that I studied this stimulation protocol, this other stimulation protocol, and what was the effect. Or I used culture media, one kind of, the other kind of culture media, what was the difference, right? And then there are some prospective studies, some retrospective studies, and how impactful do you want your results to be. So for that, you have to define whether it is a pilot study. So it could be just about 20-25 patients and it's a pilot study. If you want to do a proper research study, you have to have as many groups you have. There should be enough number, because it shouldn't be lopsided. Right? Why do we try to distribute among all to begin with? When we are doing a prospective study, why do we put enough number? Because there are going to be dropouts. So it shouldn't be just because it's इसमें 75 patients hai and the other has only 15 patients. It will not make any sense. The results will not be proper. Now, if you're after having come to a number of patients, that will give enough power to your study. Power to a study means how seriously should we take the statistical significance that we get. Then coming to so the simple basic statistical analysis is a t-test, right? So can you take me to the first table, please? Okay, data analysis below. Still down, usse bhi niche. Acha, theek hai. Okay, this table will do, table 1, right? So we do a paired t-test and a chi-square test. Okay, so that between two groups, it is mainly between two groups. For example, A1 and A2, right? Similarly, C1 and C2, or A1 and B, A2 and B, C1 and B, C2 and B, because this is how. So when we are comparing between two groups, it is usually a t-test, right? So now when you do a statistical analysis, you will be getting many options, whether you want to do a student t-test, whether you want to do a chi-square test and all. So that you have to read up and apply it.
Consult a proper statistician for
that. But basically it is
t-test. T-test is usually when the variables are you can compare them, and when the variables are not defined, go for chi-group.
Discrete or
definitely, ma'am. There's a lot of factors are there. Agreed to it.
Then the other is the one-way analysis of variance. Okay, the one-way ANOVA. If you are trying to compare 3 and more groups, that is the test that you, because if there are too many groups that you are trying to compare, then how all the 3 groups, ये हो सकता है कि एक और दूसरे में difference हो, दूसरे और तीसरे में ना हो. So you don't want any faulty result or error. So for that analysis of variance, that test will compare all the 3 groups and then give you a final result whether there is really a statistical significance. Sometimes you may see obvious changes, but it is not statistically significant. So in that case, you will see that there is a difference in all the groups, but then it will not be a statistically significant difference. So one-way ANOVA is when you are trying to compare 3 groups, right? Then apart from that, now if I want to study that, what is the, for example, if I want to find out threshold levels, right? So there is something called as the receiver operating characteristics curve, right? So when, for example, DHES and fertilization. So whether I'll get a correlation coefficient which will say कि हाँ DHES से fertilization में फर्क हुआ है, right? So I want to find a correlation between the two, DHES or fertilization में या embryo quality में, is there a correlation between them? So for that I need to find a correlation coefficient. To find out the correlation coefficient, we plot all the levels of DHES and all the levels of say fertilization percentage. ठीक है, तो एक कॉलम में I have उसमें tables होते हैं, XX table, XY table and so on. You have to select according to what statistical analysis you are doing. So for example, DHES and fertilization rate. तो एक इसमें पूरे DHES की values, दूसरे कॉलम में पूरी मेरा fertilization rates हर patient का, how many ever number of patients they may be. So now whether there is a correlation between DHES and this fertilization rate, right? So depending, अभी कुछ अच्छे से कोरिलेट करेंगे, कुछ नहीं करेंगे। लेकिन
Hmm.
मेजॉरिटी अगर कर रहा है कोरिलेट, तो फिर मेरा एरिया अंडर कर्व जो आता है, जो वो आरओसी, इट इज
Increases.
कॉल्ड रिसीवर ऑपरेटिंग कैरेक्टरिस्टिक्स कर्व, उसके अंडर में जो कर्व आता है, द काइंड ऑफ, इफ इट इज अ स्ट्रेट लाइन, सॉरी इट इज अ प्लेटो, मतलब कोई मतलब नहीं है, लॉपसाइडेड स्टडी है, राइट? सो यू वांट at least 70 and above percent, 65 and above is considered good, 70 and above is considered still better, and more than 80 85 is the best. Means बहुत अच्छा correlation है तुम्हारे ये दो parameters का, which you are trying to compare. So receiver operating characteristics curve, which will also give you the threshold value, which will also give you a correlation coefficient. अब correlation coefficient में भी there are different kinds, right? So which one are you trying to select depending upon your patient classification and all? So that is it. Then there is something called as the odds ratio, कि अगर मैंने ये किया तो what are the odds that fertilization will increase, यानी by how much percent that is going to increase, उससे हमारा odds ratio is the test which will tell me still further. So simple comparison by t-test between two groups, three groups, one way ANOVA for receiver operating characteristics curve to find out the threshold value as well as the correlation, and then it correlates, but what is the percentage by which I can see this rise? So that you can do with the odds ratio. So this is how you, these are the simple basic statistical analysis that we do. Apart from that, so there are too many. Once you get into it, it's like mathematics. The more you get into it, ऐसा लगता है ये भी करके देखो, ये भी करके, you start, it's like you playing a game. You start putting all your figures in the columns and try to see क्या आ रहा है, क्या आ रहा है. So
I think we should have a workshop for kind of how to learn this statistical this thing also.
Yes.
It's so interesting and it's quite overwhelming at times to, if someone doesn't do it, it's too overwhelming, right?
Yes, yes, yes. And that is the thing I think which puts off most people.
Ma'am has explained it in such a flowy way, ma'am, that for the kids it is very easy. Like the way ma'am has explained it in the flow chart manner, how you progress a study, start from the sample size, then go forward. It's very explanatory. Can I ask the last question to all three? I'll start with the experts first. We have always talked about the positives.
Can I say one more thing?
Yes,
ma'am.
ma'am.
Bas ek cheez, try to do the statistical analysis yourself.
Yeah.
Because you have done the study, you know कि ये patient, यानी as an embryologist, ठीक है, I know who that the patient has walked in, इसका result क्या था, इसका data क्या था, यहाँ क्या गड़बड़ हुई होगी, तो whether I want to include her or not. If you give to a person to do statistical analysis, उसको हमारे dynamics नहीं समझते, right? They will just put it together in a nutshell. तो हमारा जो plus minus standard deviation होता है ना, see you get जैसे column statistics किया, उसमें you get a t-test, but हमारा जो plus minus standard deviation होता है या standard error होता है, that is also important. यानी ऐसा ना हो कि मैं 36 plus minus 5 लिखूं यहाँ पे और दूसरे में लिखूं 40 plus minus 8, तो वो overlap इस तरह से हो गया, तो I won't have demarcated age groups.
Yeah, definitely.
Overlap उस तरह से नहीं होना चाहिए. So you only because you have done the study, you know what the drawbacks are. तो हमको अच्छा, and while doing statistical analysis, you can do a 10%, 5 to 10% थोड़ा सा, because you know कि अरे मैंने ये टेस्ट रन किया था, इसमें ये बहुत ज्यादा हो गया था, ये ऐसा हो गया था, whatever, I mean XYZ कुछ भी, तो हमको पता है कि एरर कहाँ हो सकती थी और उसको रेक्टिफाई कैसे करना है. So that is called as correction of errors. So in any study, when you do statistical analysis, you have this scope of 5 to 10% error correction that you can do only if you know, if you are doing the statistical analysis.
Plus, at times it gets very difficult to make the statistician understand what you want from the study, from the medical point of view. Gets difficult.
Always ask for a sample paper, ma'am. That's it. Give me the sample paper and I will do everything. You don't worry about it.
Yes.
Give me the data. That's it.
In our field, there are too many factors. Right?
Too many factors. Yes.
See, here, having said this, it is DHES is not the only one. There are so many other things. Plus stimulation protocol. Then the difficulty during the time of pickup. कुछ suction में problem आया सही में. So you cannot attribute everything to that molecule or anything that you are studying. You have to take all the confounding factors into consideration also.
Definitely. Ma'am, can I ask the last question? Everything we talk about positive of DHEA, and if I would say I Googled DHEA as an embryologist, I would say no, having zero clinical knowledge, what is DHEA? I Googled. I said, what are the effects? What are the side effects? It kept on saying, oh, it causes depression, mania. I'll start the question from Saroj, ma'am. So that's it. So we go from that side to the author. Depression, mania, and lots of problems in the female. Then if we see the fetus or the baby or the growing child, right now DHA is the most hottest and the most talked about subject. Ki Bonvita mein, Milo mein, Phalana mein, I will not take the name, sorry, no tagging of names, nothing like that. Any milk product which you're giving to your child, they say they propagated DHA wind, but right now the studies are going revert and the talks are going revert. It is causing attention deficiency, it is causing ADHD, it is causing autism. So there is no say right now. Lot of marketing things are going on and controversies are going on. And now in here right now, this I'm nothing related to like negative about DHA. But if we this article is stating that it is improving the oocyte, we are going at a very sub-microscopic level. We are introducing DHA. So what is your state in these two controversial? Any just few statements you can
So,
say about it?
if you're asking me, I feel every product or anything which we are doing will have its pros, cons, its side effects, and its limitations, whatever it is. So, the side effects, as I said, I mentioned, androgenic effects will be there. There will be acne, hair loss, and hormonal imbalances if you're using DHEA. That's the reason why my next question to Bindu ma'am was like many clinics are not giving DHA supplementation as such because of this, because every woman is responding different. I think the use of testosterone gel is more in many clinics to kind of give that effect to it.
Androgen.
I don't know if you, yeah, androgenic effect. There are a lot of clinics who, because they feel DHA might not work and the testosterone gel is giving this thing. But then again, saying that, I feel DHA is for a specific group and the testosterone gel is for a specific group. You cannot like say all like freeze all जैसे नहीं है कि all testosterone they will come into the testosterone group or everyone will come fall into the DHEA group, right? But then yes, you have to choose your patient wisely, and I feel like even in our clinic we are using testosterone gel, so we know which patient to give that. It's as such, so you should be knowing the history well. You should be knowing whether this is going to do more harm to them than good to them.
So it's about, see, we are talking about customized protocols and everything now,
Yes,
right? Patient
yes,
to patient. It's not a general blanket rule that
right.
we follow. Similarly, see, when we are trying a molecule like this, it goes without saying that you have to counsel the patient that we are doing this. It has no proven results. This also has to be told to the patient that we are doing this study and this is known to benefit, but it may have some side effects, which no very harmful side effects are known, but if it causes anything, do let us know immediately. So for this or for any study, this goes without saying that you have to take the patient consent and proper counseling. And like Dr. Saroj very rightly mentioned, that it is all about optimal, neither too high nor too low. It is the balance that we try to maintain. So this is very necessary. I mean, yes, there are ill effects, but then we have to tell the patient. ऐसे तो हर चीज में यार जो लेते हैं सब में कुछ ना कुछ हार्मफुल तो मिलेगा ही अभी, है ना? So many pollutants everywhere, फिर तो हमको जीना ही नहीं चाहिए, ऐसा है.
Charu ma'am, what's
I
your
think
take?
it's time. Yes,
Last Charu ma'am,
Charu sir.
your take on DHA?
Charu sir,
Yeah, I'll say we need to definitely individualize the patient. And there is a subgroup of population which needs it, and there is a subgroup of population which does not need it. So we really need to individualize the group, individualize the patient.
Yes, yes.
That's the key.
This was a fantastic discussion, I think. And thank you, Bindu ma'am. Because of you, today we have an in-depth knowledge of DHEAs, what they can do in oocyte activation and everything. Because from an embryological point of view, I think we are very limited to what our product does, whether the artificial oocyte activation will help or not. We didn't go in this detail about the DHEA supplementation and everything. I'm sure the clinicians know it better, but it's always good for an embryologist also to know this clinical part. It kind of gives you a more strength to kind of use when to use and when not to use. So thank you for that. Charudit sir, would you just ask or conclude this?
Yes, sure. I would definitely like to conclude this because all questions are so well answered. मेरे दिमाग में आता है कि मैं ये पूछूं उसके पहले it was already discussed. So really it's a nice discussion and yes, as an embryologist, I also learned so many things about DHEA. And although we have heard DHEA so many times कि ये
Yes.
होता है, ये देते हैं, लेकिन इसका क्या यूज है और कहाँ पे क्या इफेक्ट आ रहा है, this is very well understood now. So I think biggest thank to Bindu madam for giving us this wonderful paper and all other moderators and I don't have any words to say because this is so fantastically going on. I was listening quietly. That's why I was just listening because such a nice discussion. So thank you very much from iHERA team, from all of us to be part of this club. And let's hope we'll have further such journals discussed on this platform. And once again, thank you very much from all of us. And Dr. Deven Patel was there, but मैंने उनका आवाज ही नहीं सुना
there,
पूरे
he's
समय।
there,
Sir
he's
is
there.
there, sir is there, sir.
सर
I am here, sir.
अरे सर क्या बात है, कुछ आज कुछ आपने आवाज नहीं निकाला, कुछ बोला नहीं, मतलब आप भी इतने खो गए थे सब्जेक्ट में कि
Exactly. अच्छा डिस्कशन था सर आज.
कभी कभी लिसनिंग भी क्वाइटली लिसनिंग इज आल्सो गुड समटाइम्स, है ना,
Yes,
हर
sir.
बार इतना जरूरी नहीं होता है. सो एनीवे, थैंक यू वेरी मच एवरीवन एंड
Thank you,
सी
sir.
यू.
Thank you so
Sir,
much
आपका
again. It was an honor really to be here and discuss the paper. And if it can motivate any embryologist to really take up research seriously, however simple the topic may be, it will be good enough.
Corona person, please stop
Yeah,
this live.
I thank everybody. I thank all our moderators, our seniors, our can say our
Thank you,
speaker
Nidhi.
and the
Thank you.
author who has written a wonderful article which we could present it here, and all the delegates who are attending. Thank you so much for everything, and Sneha for a wonderful and a crisp presentation. Thank you to all.